discuss the 2026 value plan preview, and we'll also have a presentation on maternal health coverage for pregnancy and postpartum care, and end with public comments. So we'll move to the vote on meeting minutes. So I move to approve the Standing Advisory Committee meeting minutes for July 18th, 2024. Do I have a second?
Second.
Thank you. With that, we've approved the meeting minutes for the July 18th, 2024 meeting. Great. So I think we can. We'll start out first. I think, according to the agenda, with a brief update from Aika on the Board of Trustees activities.
Hi, everybody. If you don't know me, my name is Aika Aluk. I'm on the Board of Trustees. We've been fairly busy the past few months, I think, since we have connected in this space since July. Since then, we approved two amendments to the regulations governing small business health coverage. We did so many things. Young adult subsidy parameters. We also approved as well, particularly the option that offers a maximum subsidy for ages 18 through 33. With decreasing amounts for ages 34 through 37. So I want to be particular, as there were two sort of options presented, and we voted to approve that second option. In addition to that, there was a motion that sort of came up that was looking at proposed re-enrollment regulations that was not approved, and it was sort of a balance between the current regulations and kind of addressing re-enrollment in federal regulations and allowing states to sort of use the healthcare.gov to crosswalk between different eligible plan options. And so that one did not get approved. In addition to that, we had a discussion around waiver amendments. And so that was also approved, particularly to apply for a waiver amendment to allow Maryland residents to enroll in coverage through MHC, regardless of their immigration status. And so we've sort of been moving and grooving. We had some IT procurements that were also approved, along with just upcoming. We have a few different things on the agenda, some policy update, really looking at 2025. We meet on Monday. And so just kind of excited as we sort of set the footing for what can come for the upcoming year. But I'm happy to answer any questions if folks have any.
Which are, sorry, I have a question.
Yes, feel free.
What are the Senate bills that were approved? Were the Senate
That's a really,
or House
that's
bills?
a good question. From a policy item standpoint, I would have to, let me dig a bit to think. I feel like that's a few meetings back. So it's not fresh at the top of my head, but I'm happy to share those in the chat.
I have Senate Bill 705, Qualified Resident Enrollment Program, Access to Care.
That's the bill. Carmen, yeah.
Yeah.
That's the.
Yeah, okay. Was there another one that was approved?
It had a companion House Bill 728.
Okay, thank you.
Thanks, Amelia. And I think those were the only two, Amelia, if I'm correct.
Yep.
Okay.
Also, one more thing is on the waiver. I know that the period for comment is still open. Would it be helpful for us to send in comments in favor of?
Yes, I mean, it'd be great if, as it's open, to sort of encourage folks to engage with that period. Absolutely.
Okay.
Joanna, did you have a question? I see your hand raised.
Yeah, I wonder if you could provide a little more information about the small business coverage option that you mentioned. Is that the individual coverage HRA? I think I saw that you all might be rolling that out for 2026. Is that right?
Yeah, so there were two. one of which was a minimum participation rate, and sort of the percentage of small business employees who could elect into enrolling for coverage for the business to qualify. And then the second one would reduce the maximum waiting period for a small employer, for example, before offering coverage to qualified employees.
Oh, different from the HRA option. I think maybe you just let it, yeah, okay.
Yeah.
I'd be interested. I think it sounds like you all are just starting down that path to consider that, but I would be interested to hear more about the thinking on that. I know it's, not a big take up and it's a fairly new option. I just was curious about the thinking on that and how you're thinking of implementing it. That's a future meeting when this ripens a little bit more, but I am intrigued.
And
Okay,
Joanne,
perfect.
and
I'll
I
make a
think
note of
I'll
that.
address- And I'll address a little of that in next when I speak to.
Okay, thank you.
Thank you, Michelle.
Great. Well, hearing no more questions, I'm endorse. I'm also interested in this. So I look forward to hearing more from Michelle shortly. Was there one question in the chat? This is just encouragement to submit comments. Great. Well, I think we can move on to the MHBE executive update from Michelle Eberly, the executive director. So Michelle.
Thank you, Mark. And Aika, thank you so very much for that really great board member update. That was very thorough. I appreciate that. Just a couple other things that I will add. We are actually getting 2 new board members. So Marie Grant has been named as a new insurance commissioner that will take place, I think, in October or November. And she will become, by her role, one of the board members. As you may recall, Kathleen Borain was in that role. We have Joy, I think I can't remember, Hatchett, who is the interim. But what's really exciting about having Marie come onto the board is that Marie has been involved with the Affordable Care Act since we began. So she was first working in the legislature. She's worked at Care First. She's now at Department of Health. So she's very, very understanding and policy around the Affordable Care Act. So we're thrilled to have her as a board member. We also have a second board member that is on now, effective now, who's replacing Dr. Allen, and it's Catherine Rogers. So Kat Rogers, and we are familiar with the exchange, are familiar with her way back again to the beginning of the Affordable Care Act when she was at the Lower Shore Local Health Department. And she actually helped implement the ACA and once with one of the connector entities way back when. She has since, her name has changed. Well, she's gotten married and has pursued her career in public health. And she now oversees engagement in the community and outreach and special population focus at Tidal Health. And so she's really involved from a public health perspective in making sure that we're reaching minority populations, that we're looking at health equity issues. And so again, she will be a great addition to the board representing the Eastern Shore. She also was important to us that we had someone from the Eastern Shore, and then just her experience and her wealth of past experience and current experience will be just tremendous. So we're thrilled about that. You probably, if you haven't heard already, rates were approved. On average, we're looking at about a 6% increase in individual market rates. That's lower than a lot of our counterparts across the nation. So we're pleased with that. We will get those loaded in September, and the first notices of renewals will start to go out in October. So that will be the point in time when people see what their renewals will be. They'll see what their plans will be, whether it's the same plan. I think they're all the same plans. And then what the projected rate increase will be and what their APTC coverage will be. So that's kind of a time frame for you on that. Legislatively, we are working with Senator Feldman and Delegate Kerr, who are going to introduce a bill in next session to continue the young adult subsidy program. As you'll recall, it's a pilot program now, and it will continue for through 2020. Amelia, is it 25 or 26? I'm having a little 25 right now. Right. And so what we want to do is get that in line with what the reinsurance program is, because that funding comes out of the reinsurance program, and we know it's been very, very successful. We're working on our report with the actuaries to kind of firm that up and present that to the legislature. But we're excited that Senator Feldman and Delegate Kerr are looking to continue this program. We're really pleased about that. As far as our staffing and where we are internally in staff, we just actually today had our closeout on our Office of Legislative Audits triennial audit, and we did, I think, quite well on that. We had a few findings, nothing major, but we're thrilled with that. It's not finalized yet, it's not public yet, but that is, once that's completed, it will become a public audit. So that's just kind of the preliminary where we are. We're working on our fiscal year 26 budget, as is everyone else. And of course, it's a governor's budget, so nothing's public on that. But we are looking or anticipating that it will probably be a tight budget season, so we're preparing for that. And what else? Open enrollment, we are 100% in on all of our open enrollment preparation activities, our marketing and outreach, our training materials, our systems, our connector entities. So a lot of work going on that. And then finally, which you'll hear, we'll move into this a little bit later. The board and the leadership team will be meeting in November when we do our our annual planning and forward looking. And one of the things that we're looking at is how, again, the exchange in our limited sphere, what we can do to move the needle on affordability. We've done a tremendous job in the state of Maryland through our reinsurance program for the young adult subsidy program of really keeping premium rates low. We've also done a tremendous job in terms of diabetes coverage, and we'll talk a little bit more about specific condition coverage, but we've done a good job in the state of Maryland of lowering those costs, which overall lower, again, the cost of healthcare and premiums. So we're going to start strategizing about where to focus next and how we can work with other state strategic initiatives. And one of the things we'll be talking about in a little bit, so I'll end here, is on infant mortality, maternal health. So we'll have a little bit more on that in this agenda, but I'll stop there and happy to answer any questions if anyone has any. Oh, let me just talk briefly. I said I was going to talk about small business and I did not. So just very briefly, we are right now in the midst of updating our small business shopping portal. We just signed a contract with a firm that will do the back end aggregation, premium billing, so that we can finally get to a true employee choice model where a small employer can have their employees pick whatever plan they want under various categories, a couple different categories, and then we can have that all be done through Maryland Health Connection. We have a billing vendor that will take care of all that. We'll make sure that commissioners or the insurance producers get their commissions. So we're really, really excited about that. We're looking to roll that out next September. And the second part of that is, and Joanne, this goes to what you were asking about, looking at ICRA. And so the ICRA is the individual coverage HRA, and how we could help small employers who are interested in providing funds that could pay for premiums through an ICRA solution. So ultimately, our vision is that we have multiple pathways. If a small business says, I don't want to have anything to do with insurance, just tell me how I get my people to the individual market. We can say, this is how you get there. We can help you with that. If they say, well, I don't want anything to do with business, with the insurance, but I want to provide some money so they can get their premium cover, we can say, all right, let's talk about the ICRA. If they want to go through a small business plan and provide employee choice options, we'll have that ready for them. And if they want to stay with a traditional small business plan with one insurance carrier will be able to provide that for them as well. So that continuum of how we offer solutions for small businesses and Marylanders to get health coverage. And I'll stop there.
Could I just briefly ask on the small business topic, like what's the marketing effort around this? Like, how is the word getting out to these small employers?
Really good question, Mark. And again, for the exchange historically, we've been so focused on individual market, on Medicaid, on the periphery, small businesses. And I think a big component that we've worked on over 10 years is building our relationship with our producer community and really utilizing them as the experts and getting insurance to people and to small businesses. And so now as we move into this small business effort, we will rely heavily on our producers to help get their businesses into the marketplace. We also we've hired 2 staff to support the small business program. One is Teresa Battaglia, who is our small business outreach manager, and her sole job is to be making connections around the state, working with commerce, working with labor, working with chambers of commerce, working all over the state. She's done a phenomenal job. And in fact, she's probably further ahead than our systems are able to handle right now. So really working to get this message out. And I see that Betsy Plunkett, who's our director of marketing, put it that she'd be happy to come back and do a presentation on this. So happy to do that. But we do have a real targeted plan to make sure once we can deliver the solution that we've got everyone ready for it.
Excuse me. So in representing the Hispanic Chamber of Commerce, we have not heard from Teresa. Should we reach out to her? Because a lot of our folks, the businesses that we represent, a lot of times they come to us and they say, how can I get health insurance? So we've only been able to tell them, here's the individual plans, work something out with the producers, right? But most of the producers that come in have not been addressing the shop version. They've been either representing, Blue Cross Blue Shield regular stuff or, or Aetna. So is there some way, and again, when it comes from producers, I understand and we need to support them as well. But I think if there is a message that comes out from a MHBE that is addressing the small businesses, then they can then ask the producer, well, I'm interested in this, right?
Yes.
So
and
I
all
think,
of that. So if you go on a Maryland Health Connection now, there is information on small business there. And again, I think, we've had to measure this, and Betsy put in the chat Teresa Battaglia's email address. You can reach out her directly. We've worked with the Hispanic Chamber of Commerce. We've been, out and about in many venues. But we're having to balance getting the word out, but not having the product fully ready yet. So that's kind of where we're at. Next September will be a big launch to be able to do many more things that we can do today. So that's the balancing act we're in right now.
So maybe we need to wait until next September to really.
Yeah, I mean, we're getting the word out now, but the functionality that's there today is not what will be there next September.
Okay, thank you.
Are there any other questions for Michelle? Great. Well, thank you, Michelle. I think hearing none, we can move on to the next part of the presentation, which will be 2026 Value Plan Preview with led by Becca Lane, Senior Health Policy Analyst at MHBE. So, Becca.
Hello, everyone. I am Becca. I'm giving this preview today of the value plan designs for plan year 2026 that the value plan work group recently voted to recommend. So This presentation, I'll just let you know, is all that we have to share this year in the way of plan certification standards. The only plan certification standards we'll be having for 2026 are these updated value plan designs. Yeah, that's it. And then we'll, it's just a preview because there will be probably changes after the draft actuarial value calculator comes out later this year. So this is just an annual issue. We have to kind of design the plans first, then the calculator comes out, then we make adjustments, and then we finalize them. So next slide, please. As I mentioned, the proposed designs are a recommendation of the value plan work group. The work group was a group of 18 members from a broad range of stakeholders. So producers, navigators, insurers, nonprofit providers, state agencies. And we had 6 meetings over the summer. It's going to be an annually recurring work group. And the term limits are staggered. So some people will come back next year and the year after, some people will not. So, we'll be in touch about future years in case this is something that you're interested in getting involved in, let me know. So the value plan work group builds off of the work of the affordability work groups that met in 2019 and 2022 and focused on cost sharing and coverage and affordability in the value plans. Next slide, please. So just a little background of the history of value plans, and I guess this is, I can just kind of gloss over this because I think many people in this group are familiar with the value plans, but we first introduced them in 2020 when after the 2019 work group recommended we implement them, and so the value plans were originally focused on capping deductibles and cost sharing for certain services and having certain requirements around diabetes and also prioritizing pre-deductible coverage to promote access to care. Originally they were these, there were guidelines, but not specified necessarily cost sharing in the way that we have now. So 2020 was the first year for value plans. And then a couple of years later, we reconvened the work group, and the new iteration of the work group recommended that we standardize the value plans. So standardizing plans means that all of the cost sharing for each benefit is specified by us, by the MHBE, and so the plan designs are the same across carriers, which allows improves access to care, promotes insurer competition, and simplifies plan choice by allowing consumers to make apples to apples comparisons across carriers, which is something that's often difficult to do when kind of copays are just slightly different here and there, and people have trouble figuring out what's going to be better value. So when we standardized the value plans, we included some more diabetes coverage, free diabetes coverage than we had in the original value plans. And then this past year, 2024, was the first year of the standardized value plans. This year, the work group talked about 2026 plans. And so that's what we're talking about now, is preparing for 2026 plans. So that background, I'll go ahead and show you the recommendation for 2026 that the group voted on the next slide. Yep. So the plans are almost the same designs as for 2025. But with a couple of changes, which are shown here on this slide. The first one is a reduction in the cost of lab copays. So we were able to bring those down without affecting and the actuarial value, which I didn't explain in this presentation, but is just a measure of generosity of the plan that we're limited by the federal government on. So we have to make sure we comply with federal requirements. So we had a little bit of room to reduce the copay for lab services in a couple of the metal levels. And we did this because labs are something that people with chronic conditions or multiple comorbidities have to use a lot of. So it is a way of addressing the high cost of having for these populations that are disproportionately affected by certain conditions, which are often chronic conditions, so that we don't have to do a condition-specific cost reduction in order to be trying to address health equity. And so, yeah, we made a slight decrease in those copays, as you see on the slide. And then the other change that we made was to align the pediatric and dental coinsurance amounts, and that is because it's unusual among states to have different cost sharing for the two categories indicated there, for major services for dental. Yeah, so we had it kind of in an unusual way in the first 2 years. Now we have it aligned, which is more in line with kind of standards, industry standards. And then also what we did is change the coinsurance amount depending on the incomes of the people likely to be enrolled in those plans. So the people eligible for a 94% AV silver CSR plan have the lowest coinsurance, and then it goes up for the different CSR levels, and then people in bronze and gold are likely to have higher incomes, and so the cost sharing is the coinsurance is a little higher. So those are the only changes we made for 2026. On the next slide, I have a little timeline for the rest of this this work. So we usually, or I think almost always, bring plan certification standards to the Standing Advisory Committee before we bring them to the board in the fall. So our board meeting on this upcoming Monday, we'll talk about this there as well. Then, as I mentioned, this actuarial value calculator, which I'm realizing maybe I should just give a little more background on. It's just a calculator to help us calculate whether we're complying with the federal restrictions on how generous plans can be. So we can't make that check until they release that tool for us. And so when that tool comes out, we can double check our designs, make any adjustments if we need to, and then we'll have the board consider the designs, then have a comment period after that, and then have the board vote to finalize. So that is the overview of value plans. Please let me know if there's a concept that I didn't get into enough. I'm happy to take any questions on this anytime. Matt.
Thanks, Becca. Not a question. I just wanted to say thank you to you and the staff that made this. I had the pleasure of serving on this work group, and it was very streamlined, and it was incredibly wonky and in the granular level, and everybody did a great job. And this proposal is in front of you was unanimously approved, and I think it was just a testament to all the thought that everybody put into it. So thank you.
Thank you, Matt. All right, that's all I have. Thanks so much. Oh, Joanne.
Sorry. Because I was able to be on the last round of this work group, I do know that it was incredibly well run, and the carriers and others offered some really helpful data. I'm wondering if this was similar experience. If you know anything about like what % of people actually use, I guess you're talking about major, you said major sort of restorative services, right? I'm assuming it's a really small percentage of pediatric population that needs that level of, I'm asking because, the adult dental option for states, now everyone's struggling with what counts as the benefits that might be covered. And I'm wondering what the experience has been for pediatric major services, which I think you said is restorative, right? Generally.
Yeah, that's a good question. You'd have to, I think some requests for some claims data on that. I don't know.
If it didn't come up, that's fine. I just know that was the
Yeah,
kind of back and forth. Okay, that's fine. I'm just curious if it was something that was aired in that consideration.
Yeah, it's a good question.
Any more questions for Becca? Okay. Well, thank you, Becca. Okay, so now we'll move to the biggest agenda item, which is a discussion of maternal health and coverage for pregnancy and postpartum care, led by Michelle, Aika, and Diana as well.
Thank you, Mark. I'll kick this. Whoops, let me get my camera back on. I will kick this one off and then hand it off. So as I was alluding to earlier, if you go to the next slide, please. We at the exchange and we as a state of Maryland constantly look at what can we do to lower the costs of healthcare in the state? What can we, from our lens, we're looking at what drives premium, because we know we can have the best plans, we can do the value plans, but if people can't afford the plans or afford the care under the plans, it's just as good as having no plan at all. So over the years, we've identified certain issues. One of the issues right now that's high on our list, both as a state and also for the exchange, is maternal and child health outcomes and disparities. And this is also right in line with our focus and our efforts on health equity. We know that women and children that come from minority communities are much more at risk of having poor outcomes. And so we really want to look at that. There's two things that we've been, as a state, it's part of the statewide integrated health improvement strategy. We put a link to it there. And Maryland Health Connection, we've already, under this science, there also was a study already done on a report specifically on maternal health. So why? Obviously, why is this important? Appropriate prenatal care can reduce the risk of complications for mothers and their infants during and after pregnancy, and that may result in lengthy and costly hospital stays and or increased risk of more maternal morbidity. Next slide, please. Now, drilling this down a little bit closer to what the exchange does through our state reinsurance program is, as you know, we really pay for costly claims, and we pay that to the carriers so as to keep premium costs down for everyone. So we spend millions and millions of dollars on this every year. One of the requirements is that through that state reinsurance program, we do require the carriers to provide us accountability reports. And so we show them, these are the categories, this is what we're interested in. We want to know what you're doing to contain these costs, what efforts you're making. And pregnancy, as you'll see in the chart in a moment, is one of those top hierarchical condition categories that is reported on the reinsurance program. We're not there yet, but at some point in time, it would be nice, really nice, if we could reward carriers that do exceptional work towards containing costs through the program. We don't do that today, but that would be something that would be wonderful if we could say, you, Carrier X, are doing a great job containing costs, and we want to acknowledge and reward those activities. Next slide. So these are, and this is something we run this report every single year when we do we're required to report to the legislature every year on the reinsurance program. And so we always look at what are the highest frequency of the hierarchical condition categories among the state reinsurance program claims. And remember, the reinsurance pays for claims on and off exchange. So it's in the individual market. You can see consistent 20, 21, 22, and this date is always probably about a year and a half lag, because we have an 18-month, well, it's probably 2 years. We have an 18-month tail on the claims to make sure all those claims get paid, and then it's reported later. So it's a little bit delayed. But you can see that diabetes consistently is number one. And I'm just going to point out diabetes and the ongoing pregnancy without delivery with no or minor complications. You'll see as a condition in 2021 that was fourth in our list, and in 2022 it moved up to second in our list. So let's move on to the next chart. So now these are the highest HCCs among SIRP claims by total allowed claims. And you'll see that on here in 2022, again, ongoing pregnancy without delivery, no or minor complications was one of the highest costs. Do you have another slide behind this, Amelia? I'm trying to, let me see what the next slide is, please. Is it a chart or is it the end?
This is the end. This is the last.
This is it. Okay, so you don't see it. I was asking because you don't really see it on this chart, but you would see it on another chart if we had done, more conditions or more time frame. But you'll see in 2020, diabetes with and without complications in terms of costs was on our list on fourth. You will see in 2021, it's off the list. 2022, it's off the list. If you remember in the chart right before here, every single year, it's our top condition. The state has put together strategic efforts around diabetes management. The exchange, when we have done our plan design, we've looked at how do we get services to diabetics, zero cost, pre-deductible. We know we've capped insulin. So all the things that we have done to address diabetes in our state, and this is not fully vetted yet. This is just based on the claims spend in the state reinsurance program. And we really want to do a deeper dive so we can tell the story better. But what we've seen is that although that condition stays high, the cost has continued to go down. So that's what we want to see. And what you don't see here, I think other dates show that the cost of pregnancy was increasing. So it may have been below, but it's creeped up. So that's where, as a staff, as an agency, for our board, we wanted to start the dialogue about, okay, we've seen good results with diabetes. Let's now turn to another condition that we know is having a lot of costs, poor outcomes, and a lot of claims, and a lot of occurrences. So that's what we want to talk about today. And fortunately, Aika, is really well versed in this. This is an area of her passion, and she's on our board. So we thought we would start a little discussion moving into what we could start to think about with this. And when we meet with the board in November, this is again another item that we want to discuss with the Board of Trustees for the exchange. So I'm going to stop there. That's kind of the layup for where we go next. And I'll hand it, I don't know, Amelia, you want it back to you, or Aika and Diana?
I can chime in. Yeah, I can chime in. Thanks, Michelle. No, I think this introduction and just point of conversation helps really open up the dialogue for areas where we can think about where MHBE's authority lies to sort of address this. And so if we go to this next slide here, just continuing on with the points that Michelle elevated, I also want to preface that as we look at this screen and kind of talk about what's here, this is based off a plan with medium priced premium. And its estimated costs include 9 months of in-network, for example, prenatal care and hospital delivery. And so I just wanted to preface and make sure sort of folks were kind of on that particular notion and stage. And so right here, as we see the consumer costs for pregnancy and childbirth, coverage examples sort of really range across the meta levels. And it is just interesting as you're kind of seeing the out-of-pocket costs, and especially noting the needs across the state of Maryland, and especially when we talk about folks who are systemically marginalized communities or folks in rural areas and access to care and sort of so forth. It's a varying socio-demographic factors that folks have to be able to cover the out-of-pocket costs for something like this. And so if we go on to Amelia, I think we skipped a slide. Maybe not. Yes, this one. Thank you. And so to our left here, we see our no cost sharing. And most of these are really outside of the breastfeeding services. Most of these are kind of centered around prenatal support. And so really understanding how important that particular period is, routine prenatal visits and screenings, monitoring anemia, gestational diabetes, hepatitis B, RH incompatibility. Folic acids are really important for iron supplementation, tobacco cessation, and so forth. And then we see here breastfeeding services which can start in that prenatal, perinatal sort of preparation period that transitions into the postpartum period. But as we look to the right of the screen, covered with cost sharing, we're really centered around our perinatal and postpartum. And as I noted on that other slide, we see a lot of just some of those difference across those multiple levels. And so childbirth delivery services, vaginal C-section, and the postpartum care, mental health, and preventing violence, especially as we think about just some of those needs in that first year postpartum, especially noting how important the first 3 years of a child's life is. And so with that cost sharing, those amounts and can really vary across the board for folks. And so on this next slide, I want to turn it over to Diana to sort of really illustrate some of the differences of what this means from the lens of a case study.
Diana, are you with us?
I'm happy to keep going. Oh, you're muted by the system for some reason. Don't we love technology? Let's see here. I know I'm not the host, but maybe the host can ask her to formally unmute through the system.
I'm just gonna do that. Sorry, Diana, I'll do that now.
I don't think we have anyone muted, do we, Amelia?
We shouldn't, no. I'm not sure what the problem would be.
Maybe your particular system, Diane, on your computer is like double muting. I know sometimes those features in some of the newer computers.
You can also send her a chat that's focused to her.
I tried to mute and then unmute you, Diana. My system says that only you can unmute yourself.
That's fine.
Fine.
While we're here, so as I mentioned just on the onset, starting this dialogue, we're really thinking about where within MHBE's authority to sort of support some of the addressing, especially as in that previous slide that I noted with the cost sharing, centered around the perinatal and postpartum period. And so thinking about affordability, cost containment, and Michelle already elevated the importance of health equity and just ensuring that folks really have the means to feel supported during this time. I know this, I want to reserve some room for Diana to really provide some color for this case study. But this is just the start of, as Michelle mentioned, many opportunities for this particular dialogue, and it's going to sort of transition into the board for us to really look at what are some opportunities that we could explore as a state.
But maybe while we wait for Diana, I did have one quick question about Michelle on Michelle's slides. The top 5 highest cost HCCs, was that was total allowed claims, so that's combining the cost sharing and the insurer's portion of the claim, is that right? Or is this just an individual's out of pocket expenditure?
No, this is the total cost.
Okay.
Because this is what we use to reimburse the carriers.
Right.
So it'll be the total cost.
I'd be curious to know like how all these, conditions compare. As you said, like in diabetes, there's been a lot of consumer facing cost sharing protections. And so I wonder, how all these, what this would look like if we thought about individuals cost sharing and exposure to these costs rather than the total allowed claims.
Right, which is very important, and that's where we can manipulate it a little bit.
Right.
However, when you look at the total, the total cost of claims, right, is what carriers are pricing for their premiums.
Sure.
So we've got two things. We've got protecting the consumer, but bringing down the overall cost.
Yeah.
So that the whole premium, the system of for the premiums can go down as well.
Right. Mm-hmm.
And
And
also,
coming back to this, oh, go ahead, Carmen.
I'm sorry, it's the total cost of care, but it's not normalized by the number of people, right? By the number of cases, right? So it's all lumped together. So we don't know, like there could be very few cancers with a lot of price tag for each and many, I don't know, hemophilia with, how can we get a sense of number of claims versus the total cost?
Yes, and like I said, this has not been deeply vetted. This is just kind of at the higher level of what we're looking at with the reinsurance. But it was just, an initial measure to look at and to take note of that, hey, something's going on here. These costs have dropped down, even though the condition has stayed high. And so, we, like as I said, we have to do some more deep analysis, but we like the direction that we've seen diabetes go, and we'd like that direction to see with pregnancy go as well.
Can you guys hear me?
A little bit, maybe you want to increase the volume.
A little bit? Oh, okay. Interesting. Okay.
Yeah, increase the volume.
Can you guys hear me now?
Yeah, you sound great.
Great.
Oh, good. Thank goodness. I'm so sorry about that. I'm using a different computer for today, so I think it decided to not work. So I'm sure, thank you so much, Aika, for taking over for that particular slide. I did want to talk about this number 19, actually, just really quickly. I think a lot of those, sorry, you can go back once. Perfect. So within these buckets, of course, are a lot of different, types of interventions that can happen based on, my research and also just looking at the types of care that folks have received. And so tobacco cessation counseling and the preventing violence, like those sometimes can include home visits. It really runs the gamut. Depending on your plan. One of the things that was particularly interesting is that there is nothing about that we've been able to find about that, at least on my end, about doula coverage and while there and sort of support for during the childbirth. And we know from a lot of our study and just general looking at quality care is that a lot of the or not quality, but rather health equity lenses tend to show that, that advocacy for the mother during the childbirth process has significant, impacts on outcomes and birthing outcomes for both the mom and the baby. So that's just something to think about as well. And then these routine prenatal visits and screenings, also may not cover some of the screenings that you would think of for, some of the NIPT, like the non-invasive prenatal testing for chromosomal abnormalities, like those may not be covered, or they may have specific things like utilization review measures that need to be taken in order for them to be covered that patients may not know about. And so that's just something to add on to remember that there are some nuances within these coverage that is not necessarily known to the patient or, or clearly articulated. Hey, Matt, I see you got your hand up.
I do. I just want to, could you explain that a little more from your perspective, Diana, about the nuance to patients? Because I see like a slide like this and I see folic acid supplements and then I see on the right side a C-section, and there is dramatically different costs that is associated with these things. And not to say that every expected mother shouldn't have them, they should, but to balance out how we provide services and how we encounter the exploding costs of healthcare costs, there's got to be a balance, and cost share is what makes us be able to have affordable premiums. So I just don't want to conflate some of these services with others because there's dramatically different implications to how that we look at them.
Yeah, no, that's a great point, Matt. We appreciate that. I think we're just really, there's really no judgment intended with this slide. I think it's really meant to just show that there are certain things that we know. Of course, the carriers recognize the importance of preventive care. So we appreciate the no cost sharing for all the prenatal visits, because as Aika said, prenatal visits really help also drive a lot of the birth outcomes, and also the baby's health in the first few years of life as well. With regards to the covered with cost sharing, and we recognize that there of course needs to be a balance for how to go against the total cost and all the costs involved in having a C-section, right? You're talking like anesthesiology, you're talking the surgeon, you're talking all the nurses. And I think what we were intending with this slide is really just to sort of have food for thought for folks to think about where can we pull some levers to look at cost sharing for this. If you go to the next slide, then I think Aika, you went through this for me while my computer was not
I didn't in
participating.
detail, actually. I was going to say, if you want to add a bit more color to this, I think that'll help support the dialogue. And then I also wanted to preface, when we went back to one of Michelle's slide, specifically on that ongoing pregnancy without delivery with no or minor complications, for folks who have sort of lived through and been through that particular journey and have had friends through it, having no or minor complications, it's quite minimal. Anything can sort of happen. And so even really thinking about that, recognizing some of where some of these pieces fall in line. But yeah, Diana, if you can add some color to this slide, I think it'll be great.
Yeah, and so this, of course, just looks at it from what the patient knows, right? This is just this does not look at all of the actual price that, because if you look at the actual EOB and everything, like the numbers are, extraordinarily terrifying for a normal for an average Marylander. But I think what we're really trying to just to give the reality of, for folks, as much as the 1,355 we recognize is a fraction of what the actual cost of providing that care is. It's still a little scary for some folks who may be on these type of plans to have a C-section, an emergency C-section, one that isn't planned and was due to preeclampsia, which again, nobody wants that. So just sort of something to think about. Again, no judgment on this. We recognize that the total out-of-pocket cost that the patient ultimately ends up paying is a very small fraction of what was originally charged. It's just that we're trying to think about how can we help folks who do want to do all the right things with their birth, but at the same time, may not be able to afford $1,355 as an out-of-pocket cost for a birth. And then, it's meant to just be a view, a sort of bird's eye view on this.
Okay, I just have a question. I may not understand something, but when somebody goes in and says to the doctor, well, I'm pregnant, the doctor usually charges them something that's supposed to cover all the pre-delivery visits, right? Is that no longer done? I mean, maybe I have old information, but isn't there a pre-delivery cost of care with the visits to the doctor and the sonograms and so forth? Is that not covered by this, or is that just considered out of pocket?
So those were covered with no cost. Those were the no cost coverage. So this is just this is just for the birth. And
Okay.
this includes, the other thing that we wanted to highlight is that while we do focus on a lot of coverage for the mother, the neonate does incur charges from the very moment that he or she takes breath. And especially if the child needs to go to the neonatal intensive care unit, and the process to make sure that, for many folks who may not have the level of health literacy that we would aspire for them to have, they may not know to contact their insurer to let them know that the baby was born, and then they get the bill, and then they have to go and call them and go do all that backdating. And so we just want to just spur some ideas to talk about for our discussion on how to boost health literacy, and also to make the transition easier.
Okay, so the
And
no
then
cost, it just means
I'm just
that
going
the
to say, if you go
insurance.
to the previous slide, that may help with the two differences. Yeah. So to that left, I think you were referring to prenatal visits, which is a part of the no cost sharing.
Right, so
And
no,
so a lot of the
right.
conversation is centered around the perinatal postpartum period that is centered around with the cost sharing. Yeah.
Right, so in the no, just so I understand, no cost sharing means that the insurance is covering 100%. Or not.
I'm sorry, for the neonatal stuff, for routine prenatal
Yeah.
visits?
The things that you have under no cost sharing,
Carmen,
does that mean that the insurance isn't paying any of it, or does it mean that the patient is not covering it?
it says when it says no cost sharing, if you have a policy with a insurer, when it means no cost sharing, it means you go to those visits and nothing comes out of the pocket of the consumer. It's all covered
Okay.
under your policy.
I got it, thank you, sorry,
Sure.
I got it.
Yeah, and the nuance that I was adding on there is that sometimes patients will need to get additional things. Like, for example, if you have a history of chromosomal abnormalities in your family, like they may opt to get an NIPT, which is a neonatal, non-invasive prenatal testing, and that's a blood draw, but it does cost quite a pretty penny. And there are only very few labs that do it, so there's a question of whether your insurance even is in collaboration with those labs. And then there's also questions for parents who may birthing parents who may have, if they develop hypertension during gestational hypertension, there's stress tests for the baby that they need to go to. So there are things that are not routine that may add costs on. And given the findings that we've been seeing in research about like the increase in comorbidities and the increase in gestational hypertension and gestational diabetes in women, it's becoming more common for them to need those add-ons. Like the perfect pregnancy is no longer sort of the norm. So I think
Questions? I was just gonna say, if folks have any other questions, Diana.
If not, we had planned to use the rest of this meeting time for an open discussion with members. We can obviously still use the time for questions, but I might jump to the discussion slides, and Michelle, if you wanted to maybe kick off the discussion, we have quite a bit of time left in the meeting. We can use the rest of the time for questions and discussions on this topic.
Sure.
So just as the discussion says, any areas within MHB's authority to address maternal, pregnancy, and postpartum care regarding affordability, cost containment, and health equity. So as I said, as we move forward and begin to dive deeper into this and looking at within the sphere of influence we have, working with HSCRC, working with Maryland Department of Health, where are there areas that any of you feel would be important for us to look at, to evaluate, to ask, if we want to get more information on, what are the carriers currently doing to contain costs in these areas? If we want to have some more representation on that, or that the board should look into that more. So just open it up for any thoughts or ideas from this collective group of expertise from your vantage point.
I actually do have a question, and I know that I probably think this is, I guess, the reason why I saved it for here is, has anybody ever out-of-pocket costs specific?
Dana, can you say that again? Because you kind of froze a little bit for me.
Oh, sorry.
No worries.
My apologies. Have any of you heard of any states that have done anything to do like cost sharing subsidies for the actual birthing events? When we're looking at that slide of like the $1,300, like for I know that for Medicaid, that's a totally different story, but for individuals who may not qualify for Medicaid, but at the same time, have certain financial limitations, has there ever been anything explored along those lines?
I'm personally not aware of anything, but others may know something else.
Could you say that again? I don't know if I caught exactly
Yeah.
that.
Matt, do you know anything about has any other state ever done anything for cost sharing subsidies for the out-of-pocket cost for the birth itself? For whenever you think about a hospital visit, you think of things you have appendicitis, you need to go to the hospital, that's an emergency. But then birthing has become so normalized to be within hospitals that it seems it's kind of a little bit different in terms of, cost sharing. So wondering if other states have done subsidies to help with that.
I'm not aware of any particular state that has had an approach with subsidies, but I know that basically every carrier has some sort of complex case management assistance for folks with pregnancy or particular outlying sort of conditions. I think it could be self-referred or it could be identified in internal data of the carriers. But I will also say that there is no simple birth, right? Everyone has some sort of complications, and you're talking to me who delivered 2 of my children unplanned, right? Something always goes wrong. There is going to be something that comes up, and I think this is definitely a worthwhile exploration, because we don't have great maternal health outcomes in Maryland, and we should be doing better. And there's been lots of efforts over the years, and I think we saw legislation just this year with a major step forward on maternal health, but I think we should be having these conversations. So I'm happy that we are doing it now. I don't know what direction it should go in, but Diana, we can look around and ask some states, and actually Maya from United Healthcare, with the national carrier who has their hand up, might have something to add. So I'll shut up.
Yeah, thanks, Matt. Yeah, speaking from some of the other markets we currently operate in, I have never seen a cost sharing reduction type of situation that's condition specific. So we are in a lot of markets that offer additional cost sharing. So if you're using the term in the sense of silver cost sharing reduction plans, the state of New Mexico offers additional subsidies. Same with the state of Colorado. Those are never condition specific. The only time that a member can enroll in them is when their income eligibility fits those cost sharing reduction amounts. So anything related to that would never be condition specific. We have seen certain initiatives, kind of like you guys have done in Maryland with diabetes, but never anything that's specific to cost sharing reduction.
That's very interesting, because whenever you talk about pregnancy, you obviously can't ignore the larger picture and the big elephant that's in the room, about what it means to what it means to continue on with your pregnancy and the cost that you'll incur with that. And it that's why I'm always interested to see if there's anything that is condition specific, given what we've done with diabetes, that's for maternal health. And also, if I'm not mistaken, CMS also has they have their initiative is now that it's a Transforming Maternal Health Care. TMA is the new model that actually their applications are due soon, but I think Maryland can't apply because of our waiver. But ultimately, they are putting more of a the CMS has put a lot more priority on maternal health care, and also maternal mental health, I think, is the new one that they're also looking more closely at. But I am very interested in why, that something like that may not have been explored. I don't know if it's because it runs afoul of things that have to deal with, with non-discrimination, and the fact that if it is for pregnancy, then we're looking at just women, and it just, it's a lot of probably good intentions, but then there might be bureaucratic roadblocks is what I'm thinking. So I was just curious if anybody had heard of anything like that, or if they knew definitively that's why that doesn't happen.
I like that. I think that's a very, very, very good question.
And something that's tangentially related is, I know that we do have, we do see what the cost share, like coinsurance, is for different types of services. So when we look at delivery, And I don't know, without going back and looking at it, where that falls into line. So if we have a, 30% coinsurance on a knee surgery, but a 50% coinsurance on delivery, that would be something of interest, to see if we could kind of see where that weighs in.
Yeah. Joanne?
Yeah, just some questions. I am remembering a distant conversation about when there was a lot of work on the summary of benefits and coverage and the template, and the coverage examples in the back where insurers have to complete cost sharing for a typical person for different scenarios. One is having a baby. And I thought something came up there about, is it ever done as a bundled cost or something, or is it always broken out as separate services? I don't know how that affects affordability for either side, the insurer or the patient, but I was just wondering if that ever truly happens and what that might mean for affordability. And then my second question is, I think this came up on the slide that showed where there's not cost sharing, where there is. I think maybe you, Diana, or I could talked about the visiting nurse or some services that might reduce mortality or improve outcomes. I don't know if that's typically a covered service and what the cost sharing is for that, or where that falls, but it seems like the mental health piece is here, and support for new parents is an important part of at least the outcomes, and how those costs are covered. So those are my questions. I'm not expert in this area. I'm just curious where they fall.
And raising questions is really good because it will help us as we're looking forward to get ideas of things to get answers to.
Yeah. Aika, you want to take this or do you want me to start?
Feel free to start. I can chime in.
Okay, so what we were talking about for that slide about the cost sharing, so I think what you're talking about are like the doula services and things that are that have been, shown to provide for better, birth outcomes, more vaginal births, etc. I think those very plan dependent on whether they are covered or not. They are not required to be covered, but of course, the Biden administration has been very vocal in including other sort of what they consider what are I don't want to call them non-traditional, but non-clinician providers to get to be covered and to be more integrated into maternal health care because of their proven efficacy of their work. So I think that's my understanding, is that it really depends on the plan. And Medicaid, of course, covers doulas, but the question with Medicaid is how many doulas are willing to accept Medicaid, given that the rate that's paid for Medicaid is lower than what most doulas need in order to continue practicing.
That latter piece was what I was going to elevate it, and similar to that program, doulas just in general, the nurse family partnership is another one where Medicaid tends to cover anywhere between 80 to 90%. But again, similar, not all hospitals, not all nurses, it quite varies in the folks who are participating in that to provide coverage. And so it's a balance between a lot of different players kind of in the space. And I'll also add too, I know we talked about doulas, so thinking about that period, prenatal, perinatal, and 8 weeks postpartum, there are some sort of programs that sort of exist that are like postpartum support counselors and other folks in that way that are in connection to like your perinatal mental health counselors, but just folks that are really there to also check on the birthing parent, the family, and the new infant. And a lot of those aren't covered. So it really is kind of centered when we see in that cost sharing piece around that just perinatal and postpartum. And a lot of those services are kind of shared. And so really noting it quite varies across the board.
Is there any way to make it easier for parents who may not? Because, I remember when I gave birth, like I was the first week, I do not remember anything other than just learning how to change a diaper and treating it like it's surgery. Like, glove up, get the gauze, get the diaper, get the creams. But I was wondering if there's a way to like make it easier for folks who are not on an HMO. Like, I know Kaiser, because you're getting Kaiser, you're getting your health care from essentially Kaiser, like they know when you gave birth. But for other plans, is there a way to maybe make that transition easier to get the baby covered? So that, it kind of, so that there might be some type of, instead of having like the parent to like tell folks, or for when the first claim comes in, it kind of gets, I'm not sure how that works. So Matt or anybody or Maya from the insurers would love to hear your thoughts on, on how that process is supposed to work, and then how we can try to make the process a little smoother. Hey, Emily.
Hey, so I'm not with an insurer, but I do work as a navigator for the benefit exchange, and I also work for Chase Brexton. And what I've seen typically is that somebody who's giving birth in a hospital, they do have hospital staff that will help to put in claims to enroll the baby. And typically a baby is covered under their parents' insurance for the first 90 days. And then they would need to get like their own plan. It's a little different when it's Medicaid, but typically there's hospital staff that will do that if they're getting insurance covered through the exchange, and that does not happen in the hospital. Then they present to like Healthcare Access Maryland or a partnering entity, a navigator who can assist them in enrolling. They would just need a certificate of live birth, which they would get from the hospital upon discharge.
Got it. And then is that for every plan? Like, do the hospitals, I guess I should probably know this, but in terms of like, would this be for also like any like employer sponsored plans, or is that like limited to the exchange plans because of just like, there's more uniformity with the exchange plans, but when it comes to like, employer and ERISA and all the 90% of Marylanders who are covered under non-exchange plans are just interested to see if there's help for them as well, or if it's kind of tailored.
I don't know how it works for non-exchange plans outside of, I know for TRICARE, then the parent typically has to outreach DEERS.
I think Matt has his hand up.
I'll check on this, but I don't think there's generally a problem. If you've done any sort of prenatal visit, no carrier is going to be surprised that you're having a baby. And when you do have a baby, it is sort of cooked into the overall universe of that entry to the world. And you do probably have to, I don't remember exactly how it works for small group market, but at some point you're going to have to make a phone call and add that child to your policy, which you can do at any point. But if someone is getting prenatal care, you're going to go through the process, and a Care First or United Healthcare is going to be expecting a new beneficiary at some point. So it's not like there is a barrier to access for the child because of this.
So with my two children, I was both covered through Care First and also United Healthcare at different times. So with both of them, they were covered under my insurance for the first, I don't know if it's 60 or 90 days. And it gave us time to register the child. At that point, in fact, they reached out to us and said, okay, you need to fill out this form. But my insurance covered the baby automatically at the beginning.
And Joanne put something very interesting in the chat. She says that in ERISA plans, they're covered for 90 days. And then after that, they need to, 30 days. They're covered automatically for 30 days. And then the parent has to use the special enrollment period to formally add them to the plan. So there does still need to be an active thing that the parent does.
Oh, yeah. At some point, yeah. But immediately you don't have to worry at the point in time where you're delivering, oh my gosh, is the pediatrician going to be covered, right? The pediatrician comes in right away almost, right? And so that to us, that was covered
Okay.
until we reached out to the insurance company and had to register the child.
Got it.
I wanted to mention too, I should have added this in this discussion slide, but for any carrier representatives that are on the call, I know there's a few that noted that they do have pregnancy care management initiatives in some shape or form, and would just welcome you to share a little bit about that. I know we have a couple. Allison, yeah, we'll start with Allison, but just want to welcome carriers if there's any initiatives that you have that we could learn from. Would love to hear more from you. So we'll start with Allison. Go ahead.
Sure. Thanks, Amelia. Good afternoon, everyone. My name is Allison Monjarchino, and I'm the Exchange Policy and Operations Manager for Kaiser Permanente, working with the Exchange. So I can talk a bit about our programs for maternity, starting with programs, covering the spectrum of care from those who are at low risk for complications to those that are at high risk, and then, the programs in between for anyone. So starting with individuals who are at low risk for complications, we have a connected pregnancy care program that really expands the scope of settings available for maternity care. So, a lot of this care is delivered virtually in the comfort of a patient's home or workplace. And we leverage remote monitoring devices, fetal Doppler, blood pressure monitor, et cetera. So this allows our patients to access care where it's most convenient, but again, is more for kind of low risk for complications. On the other end of that, we do have specific programs for individuals at high risk for complications. Our perinatal service center program is for pregnant people with hypertension, diabetes, or those who are at risk for preterm labor. And for those individuals, in addition to their visits with their obstetricians, they have weekly appointments with a perinatal nurse specialist for assessment, education, and monitoring. There's also remote data monitoring for individuals with gestational diabetes or hypertension, and any abnormal readings trigger notifications for nurse follow-up. And then we also have programs for pregnant people with substance use disorders, smoking, alcohol use, et cetera, as well as perinatal case management for pregnant people who are experiencing food insecurity or unstable housing, to ensure that they receive support that's specific to their individual needs. In addition to those kind of programs at either end of the spectrum, we also have general programs for maternity and childcare. So starting with the newborn care center, we have a center that offers services to moms and babies with a certified lactation consultant within days of delivery, and they provide breastfeeding support and follow-up care. We also have a centering pregnancy program that brings together small groups of expectant mothers with similar due dates for group prenatal care visits. So this allows individuals to come together. They get instruction on nutrition, common pregnancy discomforts, stress management, et cetera. And it kind of allows for pregnant people, to establish some camaraderie, come together and learn about, childcare, pregnancy, et cetera. And then we also have a maternity call center that's available for pregnant people with urgent health concerns. They can call at any time and speak to a nurse specialist for any concerns. And then I know someone mentioned doulas earlier, and we are currently engaged in research to evaluate the role of doulas in advancing maternal care as part of our integrated models. So it's still underway, but we do have that on the horizon as hopefully something we can incorporate into care. And I will address a question earlier. I think someone mentioned cost sharing for birth and how that compares to standard inpatient hospitalizations. And so that coinsurance is at the same level. So whether it's a knee replacement or, you know, giving birth in a hospital, it's the same coinsurance amount.
Thanks, Allison. I appreciate you sharing all the information. Do we have any other carriers on the call who wanted to speak up on this subject too?
This is Katie Shabesta. I can speak for United Healthcare. So I am the Associate Director of Accreditation and Quality Compliance. Currently, pregnant members could potentially be covered for case management or fall into case management services under the broader scope of our case management program. So that program identifies high-risk and at-risk members with acute or chronic clinical needs. The case management focuses on education and engagement, improving health literacy, and then ultimately condition self-management. So those are the case management programs that we have available for pregnant members. And then we also, in addition to that, send out reminders to our members who, after they deliver, to make sure that they're receiving their postpartum care during the appropriate time period following delivery. And for 2025, we are currently exploring the potential to offer gift card incentives to members for receiving postpartum care during that window following delivery.
And good afternoon. This is Zach with Aetna CVS. We offer many of the same case management opportunities, particularly on some of the more high risk and complex situations. Matt alluded to this earlier, and it certainly is true that those can either be self-referred by the member, or there is the ability to identify those through internal data stratification and things like that. And some of those complex case management include assessment, education, care planning, medication reconciliation if needed. So those are all taken very seriously and are in addition to some of the more standard case management practices we have.
Does anyone have any questions for any of the information that was just provided? Thank you, Zach and Katie and Allison, for sharing a little bit from your individual carrier perspectives. Any questions on that, or any other thoughts or comments on the subjects? I mean, it's a large field. I think this conversation has been really informative and helpful, and we can certainly continue it offline. But any other thoughts on, particularly in MHBE's authority, kind of within our realm of what we have jurisdiction over, thoughts on how we can keep advancing this issue and advancing health equity in the maternal health field?
Is there, out of curiosity, Amelia, is there data on like, and I'm sure there is, I just don't know if I know where to look for it, about like how many births are covered by exchange plans? Like number of births in Maryland versus number of births that are carried or that are covered by exchange plans, or through people who are on exchange plans?
That's a good question. Is anyone else from the exchange that might know that? I mean, we don't have direct access to claims data. I'm sure that's something that's, it could be provided, but anyone else from the exchange that could answer that better?
Amelia, I don't have an answer to that, but I'm sure we could dig deeper and get some more information.
So, yeah, I'd be happy to do that, and we could certainly do more follow-up on that. That's a good question. Great, thank
KFF would
you.
always be my first place of looking. So if it's not on KFF, then more Googling to be done, I'm sure.
Yeah, I think it's mostly just because I always try to think about like the scale, and then like, by looking at that data, like, then drilling down, that helps inform how important it is. Like, because we have the information from the reinsurance about how birth continues to pop up as one of the top 5 conditions that the insurance gets paid out for. But then again, like looking at the number that are like, what's the denominator for that?
I'm sure some will be in CHIP too. It depends on, I mean, there might be CHIP eligibility levels that allow for kids to be in that program while parents are in the marketplace. So that's.
Any other thoughts or comments before I think maybe I'll can hand it back to the co-chairs to close out the meeting? Well, hearing none, I think we're ready to conclude a little early today. I'll hand it back to Mark to close us out. But thanks everyone for the discussion. We really appreciate it. I think it gives us a lot of information to kind of keep working off of. So we'll keep the discussion going, and thanks everyone again.
Well, thank you, Amelia. So I think we'll just end the meeting with to break for public comment if there is any, and wait a couple minutes, and then if there's none, we'll adjourn.
So it looks like, since nobody's, if folks are getting off their mute button, I will share some news before we adjourn then. So this is actually my last meeting with the Standing Advisory Committee. I have accepted a new position, so I will no longer be with Maryland Hospital Association. So because of that, we'll have to be providing another representative. But my last day is on the 20th, and after that, I am available still through my email. So I will put that in the chat. So if anybody is interested in contacting me, please feel free to do so. I will actually be going to Medicare. I'll be going to CMMI, not the ones who did the Transforming Maternal Health Model, though, different one. But it's been an absolute pleasure serving on this board. It has really helped me understand, just the incredible role and the effort that that our folks at MHBE have put in, and the labor of love that they've really done on making the exchange be the place to go to for health insurance for the lay Marylander. Like I have walked friends, family members, etc., through applications and connected them to navigators, because there are questions that I don't even know the answer to, of course. So I just really, really appreciate all of the hard work that MHBE does, and then of course I appreciate all the hard work that this committee does to help provide perspectives and nuance to the work. So thank you all. It's been a phenomenal, few years on this committee and 5 years working with MHBE. And I look forward to, I'll be quote unquote a civilian. I'll be technically a Fed, but I'll be looking forward to all your successes and wins for the young adult subsidy. I'll try to get my brother-in-law to give testimony.
Thank you so much, Diane. And we'll take that testimony. We're always looking for little video slots. Thank you.
I don't know if I'm gonna be able to get him to go on video, but I'll at least try to be like, hey, you want that thing that you're getting to continue? You should submit a letter.
Well, we'll look forward to seeing you at the federal level.
Yeah, I look forward to it as well. I'll be working in the patient care models group. So we're looking at specialized care, so bundles and everything. So exactly when you were talking, I think the bundles for hip replacements. Yep, there we are. Thank you all.
Thank you, Diana.
Diana. Well, we appreciate everything all the time you've given to the exchange and all the, you've given a lot to our discussion. So appreciate it so much. And we'll miss your voice on the exchange, but thank you.
Yeah, it's been great
Keep in
working
touch.
together as co-chairs as well. Maybe you can come back to do public comment in the future.
Yeah, I'll be just another Marylander. So yeah.
Great. Amelia, what do you think?
I think hearing no public comment, I think we're good to adjourn. Mark, if you want to formally adjourn.
Sure. Yeah. Hearing no public comment, I think we can adjourn the meeting. So thank you all for joining, and I look forward to seeing you at the next meeting.
Thank you.
All right, thank you.
Thank you.